Good morning, everyone, and welcome back to Virtually CAHSPR 2021 for day 2. We're really excited to start the day off today with our Hall Laureate lecture. Dr. Jeffrey Turnbull is going to be delivering that. And with no further ado, I'm going to turn it over to Mark Turnbull.
Okay, thanks, Maggie. My name is Mark Dobro, and I'm the president of the Justice Emmett Hall Memorial Foundation. It is my great privilege to introduce the Hall Laureate and moderate the Hall Lecture. The Hall Foundation was established in 1997, and we are a Canadian charitable foundation that supports the legacy of Justice Emmett Hall, often considered one of the fathers of Medicare in Canada. We award the Hall Laureate to recognize and celebrate excellence among those leading or undertaking health services and policy research, and those critical to building our capacity in Canada for evidence-based health policy development. Since 1997, the Hall Foundation has selected 19 previous Hall Laureates. And since 2006, we have selected a new Hall Laureate each year until now. Dr. Jeffrey Turnbull was selected as the 2020 Hall Laureate, and the pre-COVID plan was for him to deliver the 2020 Hall Lecture at CAHSPR. But given the uncertainties during the initial stages of the pandemic and the decision to make CAHSPR 2020 a virtual conference, the Hall Foundation board made the decision to postpone the Hall Lecture so that Dr. Turnbull could deliver his remarks in person at the following 2021 CAHSPR conference. While we may have been overly optimistic in the very early days of the COVID pandemic, it is clear that so much has changed, including CAHSPR's ability to deliver a full-scale conference virtually this year. And kudos to CAHSPR's conference team. So it is my duty and pleasure to give you some background on our newest Hall Laureate, Dr. Jeffrey Turnbull. I had the privilege of working with Dr. Turnbull when we were both members of the leadership team of Health Quality Ontario. In a field of care, I've never met anyone who exudes caring more than Dr. Turnbull. He's a committed medical educator with special interests in poverty and health equity, and has studied the effects of poverty on health both nationally and internationally. He is one of the founders and is currently the medical director of Ottawa Inner-City Health for the Homeless, which works to improve the health of people who are chronically homeless. Dr. Turnbull has a BSc from the University of Toronto, a master's degree in education from the University of Western Ontario, and a doctorate in medicine from Queen's University. He also achieved specialty certification in internal medicine. Dr. Turnbull has a number of clinical leadership positions, including Department Chair of Medicine and the Chief of Staff at the Ottawa Hospital, Chief Clinical Quality and the Health Equity Clinical Lead for Health Quality Ontario, and the Senior Medical Officer for Correction Services Canada. He also has held a number of professional leadership positions, including the President of the Medical Council of Canada, the President of the College of Physicians and Surgeons of Ontario, the President of the Canadian Medical Association, and the Vice Dean of Medical Education at the University of Ottawa. And he is the recipient of several national and international awards, including the Order of Canada, the Order of Ontario, the Queen Elizabeth Diamond Jubilee Medal, and an honorary degree of law from Carleton University. So with that, I'm very honored to introduce Dr. Jeffrey Turnbull as the 2020 Hall Laureate and the deliverer of the 2021 Hall Lecture. Dr. Turnbull, I turn it over to you.
Thank you very, very much, Mark. That was a very generous introduction. I really appreciate not just the opportunity to speak today, but also to be the Hall Lecturer for 2020. So thank you very much. And what I would like to do, if I can, is set out to you some specific challenges for CAHSPR and those people listening, and at the same time, open it up at the end for comments from the audience and questions. So I've chosen the title of Health Inequity, How Canada's Healthcare System is Failing Our Most Disadvantaged. And I think that that is intentionally controversial and challenging. So if we could go to the first slide, or the second, the question that I have is, and I'll ask you to think about this throughout the presentation, is what would Emmett Hall think about health and healthcare in Canada today? Remember that Emmett Hall was born in 1898, the son of a dairy farmer in Quebec. They moved to Saskatchewan, He entered law, and his law practice progressed significantly to a point where he was appointed to the Supreme Court. And he was an outspoken supporter of social justice and tolerance. He made very influential changes to law, education, indigenous rights, and, as we've heard, medicine, healthcare. And so when he was appointed by John Diefenbaker, a fellow conservative, to chair the commission on the future of health care in Canada that was promoted by the Saskatchewan premier at that time, Tommy Douglas. And so the medical community breathed a sigh of relief when it was Emmett Hall, an establishment conservative, and they thought that he would finally put an end to the scourge of public health care. John Diefenbaker then lost the next election, and in 1964, Emmett Hall submitted his report to Lester Pearson. And to the surprise of many, I think the result was that he not only supported publicly funded universal health care, but he actually went much farther than anything that Tommy Douglas had ever considered. And so that aspect of social justice, doing the right thing, I think he'll be remembered for that. And as Mark said, one of the founders of Medicare as we know it in Canada today. It's interesting to note that he said at that time that there's only one thing more expensive than good healthcare, and that's no healthcare. And so I think I'll ask you to bear that in mind as we go through our discussion today. And then right at the end, I'll return to Emmett Hall and ask him and all of you what he would have said about our healthcare system today. So if we could advance the next slide. I'm going to make three arguments. The first is health inequity in Canada is profound, probably bigger than any of us really ever imagined. And I've always thought that the healthcare system had this role or opportunity to address some of the inequities that are inherent within our system, whether that be rural remote, promoted by rural or remote settings, or whatever that might be. But the healthcare system had this chance to actually minimize that. And I would argue that if anything, it's indifferent, and sometimes it makes the inequity worse. The second argument will be, if you can go ahead one slide. For disadvantaged communities, our healthcare system is unacceptable. It's inaccessible. It's unacceptable in terms of the way it's presented. It's inefficient and ineffective. And I think that depending on the disadvantaged community, there's varying degrees of this, but we'll explore that in a minute or two. And the third slide, for all of you in CAHSPR and those people who are interested in research and promoting policy development and healthy social policy that supports health, I think it's important to recognize that we need to do something different, that inequity is profound. It's not getting better. The more we invest in health, that health seems to be towards those people who are in the highest socioeconomic bracket or the least disadvantaged. And so we need to think structurally of a new way of doing business. Do we want one model of healthcare and we force everybody to comply and be part of that model? Or do we think of unique community-specific healthcare models, all with the same principles and all with the same accountability and outcomes? But I would argue that our current models are not effective. We need new models, and that will require a fundamental reconsideration of health and healthcare for all. So I'm going to try and pursue these three models in the next 40 minutes or so, and or the three arguments, and then we can have a time for a chat at the end of that. So if we could go ahead. I think it's important that we begin with a case study. And this case study is, I think, really bears repeating. It's something that when I was the Senior Medical Director for Correction Services Canada, I had the honor of, or task of reviewing all of the deaths while in custody. These were deaths for natural causes. And so I would review those, and I found this remarkable similarity of just about every case. And in fact, in my practice caring for the homeless for the last 20 years, I would say that these are not uncommon. They're by far the majority of cases that we hear. So this is of a young lady who died in custody, 42 years old, a female, died of pneumonia. She had diabetes, HIV that was untreated. She rapidly, progressively deteriorated while in custody, federal custody, and despite oral antibiotics, died. And that would be it. Case closed. Cause of death, pneumonia. However, I think it's important to read behind that. At the age of 6, this person was taken out of her family circumstances by Child and Correction and Protective Services because of abuse from a mother with a challenge of addiction and a boyfriend. She was put into foster care, where again was further abused, and moved from foster care setting because of disruptive behaviors. Couldn't stabilize in schooling, and after a period of time left schooling, and then was reacquainted with her mother as a young teenager, and again the abuse started once again. And it was around when she was 14 or 16, I think, that she actually left, and she migrated into the homeless environment. And her addiction started around the age of 12 with alcohol, marijuana. It progressed to other stimulants, and she was an injection drug user before she was 20. During this time, to support her injection drug use habit, she had many different infractions. She went into drug court. She was incarcerated on several different times into the provincial system. And then finally, because of the continuation of her problems in terms of drug use, she was ultimately taken into the federal system and incarcerated 2 times in the federal system. And then ultimately, while in the federal system, because of further crime within that system, her sentence was extended, and she then moved up into a longer stay, more intensive setting in the correctional system, and ultimately then, as I mentioned, died at the age of 42. And so during this period of time, I looked to see if she had had any interactions with the healthcare system. She had had many interactions with the emergency department. She had had many different interactions through the prison system. She was felt to have ADHD. She was felt to have fetal alcohol syndrome. And of course, her addiction, and then HIV and Hep C, complicating both of those things, which she refused treatment for. The question is that I think that I would ask you all is, does anybody think this lady died of pneumonia? I would say that she died of a widespread failure of almost all social support systems, that she was born into a circumstance, and then no one tried to effectively deal with the consequences of early childhood trauma, poor social development, lack of education, and then repeated consequences of incarceration and a life of crime and addiction. That is sadly the story I see just about every day. And I don't think it differs that much. So the issue here is, what would Emmett Hall think about that story? So if we could go to the next slide. So what is health equity that we're talking about? This comes from Health Quality Ontario, as Mark mentioned. Health equity allows people to reach their full health potential and receive high quality care that is fair and appropriate to them and their needs, no matter where they live, who they are, or what they have. That's what health equity is. The fellow on your left is a young fella in Southern Ontario, the fellow on your right, born on the shore of Hudson's Bay. Both around the same age, both males, both citizens of Ontario, and that's just about where the similarity will end. The fellow on your left will probably live anywhere from 10 to 15 years longer than the fellow on your right. The fellow on your right will suffer higher frequency of, or likelihood of suicide, diabetes, disability, addiction, all of those things. And I'm going to explain some of those in a minute. But for those people listening, this is anything but fair. So I think there's that concept of fairness that underlies health equity, and the need for us to address that is huge. And I think if we can go to the next slide, I think most people would say, yeah, we do have a healthcare system that is somewhat inequitable. We have health that's distributed inequitably, but I don't think that people really understand just how significant that is. So this slide looks at the life expectancy in Canada from the UN life expectancy reports. It's, I'm not sure if you can see it, but it's 82.96 years. And when we hear that, we say, great, it's progressively increasing throughout the years. And super, 82.9 years, we're all going to live that long. And if this Gaussian curve or normal curve was really tight, all around 82.96 years, that would be super. But that is not the case. This is a very widely distributed curve. There are people who are going to live substantially longer than that, and there are people who are going to live substantially less. So if we can go to the next slide, I've tried to pull out from some different reports, etc., some from the public health literature, some from different aspects of the public, from CAHI, etc. So look at Canada, 92.96 years. If you happen to be the lowest socioeconomic bracket in Canada, well, that drops by 5.9 years. If you happen to identify yourself as Métis or come from a community that has a high number of individuals who identify themselves as First Nations or Inuit, you can just see how the life expectancy drops dramatically. And then homelessness, that's minus 21 years. The likelihood of getting to the age of 75 in my community is only 25%. And you know, if you look at the life expectancy growth over the last 100 years in Canada, it's 20 years. The homeless have missed out all of that development and improvement in our health, and their life expectancy is the same as it was for the general community 20 years ago. And so if you think about it internationally, on the other side of both sides of the homelessness bar there, you would find Mozambique and the Democratic Republic of Congo. That's their average life expectancy. So it gives you a good sense that that is a very widely distributed curve, and many people are paid for their social disadvantage, their racial disadvantage, their location, etc. And they pay for that in terms of their life, their health. So let's go to the next slide. Just to give you an idea, this is not just associated with mortality, it's morbidity as well. And I've tried to look at many different disadvantaged communities, but you can see on the left side, all of them, from addiction, obesity, trauma, mental health, suicide, diabetes, asthma, all of them are higher in these disadvantaged populations, and substantially higher, 1.5, 4 times higher. So if I'll just read some of these, lowest socioeconomic group, 11.3 fewer healthy years compared to the highest, 1.6 times infant mortality. Suicide follows a socioeconomic gradient. Asthma is 1.5 times, diabetes 2 times, obesity 2 times. It goes on and on and on. So both morbidity and mortality are dramatically different in vulnerable populations, in disadvantaged populations. And if you think about what would be a blockbuster drug for us, something that got us to live a couple years longer with less morbidity, maybe for 30% of the population, well, of the population who takes the drug, these impacts are so much, they're just out of another stratosphere of how big this influence is on those populations and how much they suffer as a result of inequity. So we'll go to the next slide. So hopefully I've convinced you that, inequity is very substantive in Canada, and health inequity is very substantive. And so let's now turn to who are those people and why we should try and fix this problem. And then we'll think about how we would fix it. So who are they? Canada's most disadvantaged communities are right throughout. They're not unique to one area. They have overlapping and compounding risks, often generated by the social and structural determinants of health. And in the core of that, the one thing that I'm impressed with, that poverty is probably one of the biggest drivers of all of these things. And so they have overlapping social determinants with poverty in the middle. So it's not just one thing, that if you're poor, you're often poorly educated, you don't have a job, you may be in a rural, remote setting, or you may come from an ethnic or cultural background that might predispose you. So the other thing I think it's important to say, that in an effort to try and address this, our healthcare system basically fails. We expect those individuals to access a healthcare system that is designed and built for people like me, white, educated, middle age or so. And when those people can't access that healthcare system, we think it's their fault. And I would argue that's not the case. It's our responsibility to develop systems of care that serve that community, that would reduce the inequity that they experience. So a healthcare system, it may not even be there. If it was there, it might not be accessible to them. So in my setting, we have available orthopedic surgeons who can operate on total knee joint replacements and improve morbidity and functional repair. So, but can any of my homeless people access that? No, they'll never even get on a wait list. So we can't even complain about how long they have to wait. They just don't get onto a wait list. And if we did have that service and it was accessible, it might not be acceptable to them for cultural, religious reasons. And certainly it's not accountable. So I think our healthcare system it's failing these communities, and I think we need to do more. And I would argue that this is probably one of our greatest priorities. So if we can go to the next slide. Can we go forward and not backwards? Unless you thought that I actually should say something differently. Perfect. So who are these communities? I've just tried to list some of them. There are others. And I think that the important message here is they are ubiquitous. They are everywhere. And if you think that you're going to end up practicing or serving communities that aren't represented here, then you would be wrong. I think you will see people in whatever circumstances you find yourself with members of these different communities. So if we go ahead. So this is a complex slide, and I'll try and work through it. So why would we make the case for health equity? So the first bit down, if you look down below, is quality, social accountability, and that was the kind of it's the best thing to do. It's the right thing to do, and that's captured by John Donne's quote: "Any man's death diminishes me because I'm involved in mankind." And I think that sense of social accountability that is now creeping into the discourse is a good one. If you look at the quality literature, as Mark mentioned, there are pillars of quality. Were initially safety because of the concerns about medical error. Then because of wait lists, timeliness became a second pillar. And then because of budgetary constraint, effectiveness and efficiency. And then because we weren't listening well to our community, then patient-centeredness. And then almost as if it's an afterthought, equity was the sixth. And I think we've addressed many of them, but we have not addressed well in a quality system the last, and that's equity. You can't have a good quality healthcare system that's just good for a few people. It has to be for all. So that was the quality, social accountability, the kind of the right thing to do. And many people within these communities, because there has been a charity focus to a lot of this, have objected to that and said, hey, wait a second, I'm not somebody who deserves your charity. I'm somebody who has a specific right to reasonable care. And Canada, through the Wellesley Institute, outlined in 1948 was our first international treaty that guaranteed the rights of health and health care and equity to its citizens. But we've signed on to about 5 or 6 of them, some binding, some not. And we don't really comply. And sooner or later, somebody's going to start to say, wait, this is a human right that should be expected of all of our citizens. And I think that the human rights agenda will force our next level of priority to get this done. And then I've written down, and maybe you've heard me talk about it before, but I don't think we can afford to keep going along the way we're going. It's costing way too much. The care that is provided to these challenged communities or the disadvantaged communities is both expensive and ineffective. And so if you look at any models, the lowest socioeconomic bracket uses 2.5 times more than the upper socioeconomic bracket in terms of healthcare costs. The lowest 5% of frequent users of the healthcare system use up about 60% of cost. And who are those 5%? They are challenged and they live in a world of crisis and disadvantage. And those are the people who deserve our efforts towards addressing their equity or inequity. So, we fill up our prisons at, $47,000 to $92,000 per year per inmate, and we have 40,000 of them. And who are they? 40% have a history of one or more mental health issues, and 80% have a history of significant addiction. These people should be redirected into a healthcare system, an environment that actually can help them and allow them to achieve a more effective life and quality of life. So we're spending billions. In my world, homelessness, they think it's about $7 billion a year. The average homeless person, $35,000. wouldn't it make sense to just try and provide them better care in a different model and support that with different social services? It would be cheaper and it would have better outcomes. So I think that those are the reasons why we would think about trying to make the case for health equity. So if we can go ahead. So what is the challenge then as we start to think about, well, if we were to try and address the challenge of health inequity within our healthcare system, what is that? Well, we've heard through the patient-centered care literature, it's got to be the right care at the right place at the right time. Well, I would argue that community-centered care is exactly the same. And we have to listen to those communities and say, what is the care that you need? How can we provide it? And how can we do and measure the outcomes in ways that are effective to you? And what needs to take place so that we adjust rather than we demand you to fit within a model of care that's inappropriate for you. And so if we can go ahead, this is going to require a lot of work, obviously. We're going to have to think about how we engage with communities very different. We're going to have to think about how we collaborate with different partners. On an average day, I'll explain to you in a bit, in caring for the homeless, I probably spend more time talking with social services in terms of housing, police services in terms of judicial, than I do treating HIV or tuberculosis. It requires trust. And I think we all have an obligation to advocate for those people who are voiceless in our community, who suffer so much from health inequity. So this is the challenge for us. Now, if we can go ahead. If you think about what are the elements of these models, the models themselves, we have to define the circumstances for the individual or community. We have to think what good health is, not from my perspective, but what their perspective is, and consider personal systems-based barriers, of which there are enormous numbers, preventing them from accessing care and health that they think is appropriate. We have to engage those communities and individuals in an effective solution, and we have to have the right care, and we have to build trust, as I mentioned. And then we're going to have to start to work on some of those downstream factors that are bringing these people into this circumstances in the first place, and how do we advocate more effectively for them? And germane to this population, to the people at this conference, it's how do you measure success? How do you promote good, effective public policy? How do you drive good change through evidence? So next slide. So I'm going to give you an example just before I end of what could be a reasonable model and the things that we've been doing in terms of providing services for the homeless on their terms. And is it effective? Is it cost effective? But I'll try and outline that for you. Not that you should duplicate exactly what we do, but more so, this is the process that we went through for the last 21 years in trying to support this community. So think about homelessness. There are 35,000 homeless people in a shelter in Canada last night, about 235,000 annually. This homelessness is a relatively new phenomena since the 1980s, when there was cuts in terms of social services and housing. And that's led to individuals increasing numbers moving into our homeless environment and shelters for support. And if you think about them in that context, the predominance that I see of the chronically homeless, which is about 20% of all of those people have mental health challenges and a history of addiction. And so the homeless themselves are a changing environment. We used to be the adult male alcoholic We've now have families and refugees, the very young, the very old. We have a wide mix of different heterogeneous communities that find themselves in a setting of homelessness. And so in that context, we recognized some time ago that these people suffered inappropriately as a result of their health and their circumstance, and we needed to do something differently for them. And we sat down with them and designed a health system for them. So if you can go ahead to the next slide. So we started off small, and we have grown to the size of a medium-sized hospital, if you will. We provide shelter-based services throughout all of our shelters. And we started off with a hospice and a special care unit for men for people who are transitioning to and from the hospital. We started with a managed alcohol program. And then we recognized that these people very quickly stabilized. We put them in a stable environment. The chaos of their life stopped. And they started to say to us, we want to be in a much more stable environment away from Lower Town in Ottawa. And we want to move to a setting where we can meet with our family, cook meals, get a dog, garden. And so remember, these were inveterate street alcoholics or injection drug users. And so what we then started to have to respond to is we had to then develop residential housing for them, supportive housing, where we could continue the care for them, and we would continue it on in a residential setting where they were stable and they were repairing their lives. So we started with managed alcohol, and we stabilized them, and we moved them to a hotel called the Oaks. And at the Oaks, these individuals who have refractory alcoholism now started to have parties, and they come to my farm and they cut Christmas trees for themselves. They invite their family members to parties. They, have pizza day, all those kind of stuff. And their outcomes in terms of their health and their health promotion strategies now have exceeded the standards of the housed population. And they're not in the emergency department anymore. We have women's programs. We have programs for individuals who have mental health and addictions, and the elderly. And you can see all of the programs there, but I'm going to come back and talk about Carruthers, the mobile van, MOP, Safe Supply, and the CTS when I talk about the challenge of opioids in this community. But what we've done is we've listened to this community. We provide services on their terms, where they are, and we do it in a stable environment. And that seems to be the secret sauce. So, and we treat their mental health and their addiction in that context, and their physical health. If we could go ahead. So I said I would come back to some of those elements in a minute or two, and it relates principally to the opioid crisis. And I'm going to give you two examples, the opioid crisis and COVID. And I do this because it demonstrates elements of the healthcare system that you have to provide for these communities that show that you're capable of responding to their needs. And you have to be flexible and nimble. And so the opioid crisis, obviously no one needs to, in this audience, needs any background about that. It has been epidemic for us. It has progressed to a point where we were having, maybe 2 overdoses a month. And then the next month we went to 35 overdoses. The month after that, at the onset, we were up to 75 overdoses. So you could see this building with the early development of fentanyl, its analogs, and then all of the contaminants of fentanyl that go with it, such as benzos, etc. And now the addition of stimulants such as methamphetamines, and we've always had crack cocaine, but that's still there. And so we needed some way to respond. And the first thing we said, well, we got to keep people alive. So we started what you can see here, what we call the trailer. It's an SIS, or in Ontario, it's a CTS. Basically, this was the first line of stabilization. And currently, with the presence of COVID, I have to say we have about 150 to 200 visits in a day. We have 15 overdoses every day. And so we've become quite good at managing overdoses, and we've had no deaths in the trailer since that time. So when you think about the trailer itself, you allow somebody to go out and steal or commit street crime to get enough money to buy poison that they inject, you watch them inject, you resuscitate them, and then you allow them to go back out and do that again and again and again. And listening to that community, they said, that's not fair. You're committing us, yes, you're saving our life, but you're committing us to a life of ongoing abuse and addiction. And so we started what's called a managed opioid program that we stole from Vancouver. We give dilaudid IV, but we did it in the context of a residential setting. And that was one of those settings called Carruthers. And with John Howard, we took over a hotel. We give IV dilaudid to these refractory opioid addicts at very high risk of death. And there we provide them, good social services, mental health support, addiction support, and physical health support. And over the course of the last 2 years, again, we haven't had no deaths, and we've had people now volunteering and trying to get their lives back and meeting with families and going back to school. So that seems to be what we've reproduced with managed alcohol to managed opioids. That seems to be a very effective strategy. But because of the size of the problem, we needed something else. So now we've broadened our perspective to a safer supply program where we have a prescribed oral dilaudid program for those people who failed other existing treatment modalities. You have to be quick, you have to be nimble. It's not sometimes the most widely thought after, it's controversial, but it's the right thing for that community. If we can go ahead one more slide. Then when we were dealing with this, the opioid crisis, around that time, we were hit with COVID. And again, just to show you that the healthcare system had to respond, that we created had to respond. And we were told by the homeless community, look, public health tells us that we have to be physically distanced, we have to be tested, and we have to be vaccinated, and we have to use PPE. And they said, I live in a 70-bed room. There's one washroom for that 70-bed room. There is no hand sanitizer because people drink it. And I don't have PPE, nor will I be able to have PPE. And if you test me, where am I going to go? So within a space of weeks, we created an isolation center. We decanted people to hotels. All of the sewers in Ottawa were making gowns and masks for us and the homeless. And we as a community got together and responded. And then one day on a Friday, I think we tested, we were doing widespread testing through our van. And at that point in time, public health at around 3 o'clock phoned and said, oh, did you know you've got 80 more positive cases and they have to be isolated? And by Monday, we had a second isolation center open. And again, that program is being very successful in trying to stabilize people. But once you've got them there in an isolation center, we can start to work on all of their other issues and bring them into effective care. And so I give those examples of how you have to respond and how you have to be able to adjust to the needs of that community. And that sense of neglect or helplessness that this community feels by a healthcare system or policymakers who are indifferent to their needs. If we can go on, I'm just about done here. So if we want to think about what are these models, what they look like, they have to be built on values and trust around communities' needs, not ours. You're going to need new partnerships that you've never envisioned before. And I have to say that many existing policies and procedures can be impediments to actually effectively delivering that service. And germane to this population, to all of you, it must be driven by data and evidence and accountability. But we are way too risk adverse. We are way too slow, and we've got to move up the pace. And in the end, it's about changing culture and finding meaning and engaging communities. So next slide. So what would Emmett Hall say? You know, I think he would agree that all Canadians deserve the same potential for health and access to high quality healthcare based on their needs. I think as well, and I'll read another quote from him in his report, nothing good will survive unless we are willing to reform and adapt to meet changing circumstances. The principles are what counts. All the rest can be arranged. Another quote from somebody else, not his, was, "Here comes the judge, there goes the status quo." And so I kind of love that. So I think Emmett Hall would say that we have a problem. I think he would say that it's one that deserves our attention and reform. And so we can go to the last slide then. This is a quote that everybody knows about. And in ending, I'd like to say that certainly myself and my colleagues and those who serve many other disadvantaged populations, I think we're tired. We're tired of indifference. We're tired of inequity. I'm tired of phoning people to tell them the family member has just committed suicide or died of an overdose. And we need your help. And we need your help to drive evidence-informed social policy, to advocate for people who are voiceless. We need your help to address health inequity in Canada. And I'll stop, and I would love it if we could answer any questions. Thank you very much for your time.
All right, thank you very much, Dr. Turnbull. We have a number of questions that have been posted, so I am going to start asking or sort of stating the questions for you to respond to. There's some questions that are addressing some of the similar things, so I'll try to potentially group some of those questions together. The first question is, how do we develop systems of care that serve the communities that are vulnerable? What has to happen?
So first of all, we have to recognize the extent of their disadvantage, and we have to engage with them, talk to them, find out, you know, what it is, and gather information as to what their perspective is, the nature, the impediments to getting effective services. And that may be geography, it may be stigma, it may be racism, all of those things. But they are invariably, the community will know the answers. They just need you to help them formulate them and drive evidence to change.
So I've got a sort of a related question, and it says, social determinants of health are extremely important, but why should this all be the responsibility of healthcare rather than a larger system?
Yeah, that's a really good question. And I think one of the aspects as a healthcare provider is you look at some of these things and you say, that's draining the ocean. You know, I can't deal with that. On the other hand, then there's another apprehension saying, I don't know anything about housing, which is, in my circumstance, that's true. But I can stand up and say, I know nothing about housing, but I know everything about the consequences of not having it, which is also true. And I think just bringing our voice to that is important. I think we have an obligation, frankly, to speak up about things that when we see inequities in health, I think to be silent basically means you condone it. And when you see the huge difference, I'm looking out my window here and I'm looking at Lower Town, Ottawa, and I can go up a kilometer away and life expectancy, as I've said, will change by 21 years at least. Like, that's not fair. My hospital that I was the chief of staff of has a operating budget of $1.16 billion. Yet right here, any investment, there is no investment in terms of substantive health.
The next question is, what is the biggest barrier to achieving health equity in Canada, in your opinion?
Another challenging question. Don't you have any easy ones there, Mark?
I'll look.
No, the biggest barriers, I think, are that we need collective action, and we're fragmented. And the people who are in power generally have a pretty good healthcare system, to be honest with you. You have to wait a bit for your total knee joint replacement, et cetera, but you can access it and you'll get an MRI, et cetera, et cetera. Those people are the people who influence change, and investments into healthcare have been very quickly sucked up by the richest socioeconomic bracket. And whereas the poorest, they are voiceless. They are not capable of influencing the policy agenda, and we need their help. We need to help them in that.
So the next question is asking about sort of models of success around the world. So are there any other countries or provinces that we can learn from who have made progress in health equity?
Yeah, there are. And the biggest investment, if you wanted to reduce health equity, it would not be in the healthcare system. You would do it in some of those other social determinants. And so if you look at some jurisdictions where there is less of a socioeconomic gradient, if you will, and greater social support systems, and I'm thinking here of Scandinavia, for example, their outcomes are much more effective than ours. And so the question is, I think, if you want to give exemplary care to a small percentage of your population, or do you want to give very good care to everybody? And I think it's the latter. I'm willing to wait for my total knee joint replacement, knowing that a homeless individual will also be on the wait list with me.
Okay. The next question is, how do we change the culture that focuses on asking questions about what is wrong with you to what matters to you?
Yeah. Yeah. It comes part of our DNA, I think, in part that we say what's wrong with you, as opposed to listening to those individual and what are important things from them. When I started 20 years ago, I was going to come down here and I was going to cure the homelessness. I was going to come down and tell them what to do. I got set straight very, very quickly. And it's been a 20-year learning process of just sitting and listening to this community. And whenever we did that, we led to very successful programs. And so the issue of what matters to people and how do we're in service of to them, and how do we get them to where they want to be, not where we think they should be or how we think that they should get there.
Okay. The next question is, having sectors continue to work in silos is not an effective strategy in addressing healthcare inequities. How do we change the historic silos in health and social systems? Another easy question.
Yeah, thanks. So I think we have to really reinforce programmatic, integrated, intersectoral collaboration. And so that's easy to say, exceptionally hard to do. So this would be working in programs that serve communities, whether they may be indigenous or rural remote or the elderly, the frail elderly, but it has to be an integrated programmatic approach. And the only way to accomplish that, in my mind, now that I've been part of this for some time, is to think of new governance strategies and new funding strategies. And that is exceptionally threatening. So not easy, but I think you have to change the governance. You have to change the funding. Otherwise, we just fall back into our usual silos.
Okay. These are all going to be tough questions. They keep coming in.
Yeah, this is a tough crowd.
Okay, so the next question is, many of the lifelong traumas start in childhood. Do you have suggestions on how child and youth services can be improved to better address issues earlier in life?
So we know from cost-effective strategies that this is where, if you had $1 to invest, this is where you'd invest. The second one would be in housing, but and not healthcare. We have to somehow fix a broken child welfare system, and we have to support families, because some of the difficulties that occur in a family setting occur because of poverty and domestic violence arising from that, or addiction, mental health. So we need to reach out to those families to support them better so that that child doesn't also become a victim. But at the same time, if we can invest more strategically through early childhood development, right through the school system, understanding the challenges that many of these children face, right through social services, all the way through. But we have to invest into the young. You have to get them off the street, where they become part of my world. I want you to put me out of business.
Okay, so it feels that in this virtual platform that we're so efficient getting questions to you that you don't even get a second to pause. But we have a number of questions still to go, so I'm going to go to the next one. This question, a little bit different. It says, what does the evidence base that we need look like? And how should we be measuring collaboration, trust, etc.?
And some of those things are exceptionally hard to evaluate. But why don't we just begin with evaluating some of the outcomes that have been identified by that community as important to them. So that might be something like reintegration with family. That might be getting back to work. That may be stabilization of some form or another. These would be different outcomes, and the outcomes requires different strategies, techniques, if you will. They not necessarily quantitative. They could be qualitative outcomes. And we have to start moving into that direction as well. And so narratives, etc., will become important outcome measures for this community, because sometimes that's how they deal with it. Their life is in stories, and that's important to them. So why don't we start measuring in some of those things? And I know there's quantitative statistics that we need to do. I recognize that, but I think we have to complement it by what's important to them.
And I think it's reflected in some of the case studies that you brought forward in your lecture. So the next question is sort of framing this about the innovations I think you talked about sort of near the end of your lecture. And the question is, a lot of these innovations are so specifically tailored to local populations or targeted to meet very specific needs. This can make them harder to scale, spread, and sustain within our existing health system resource funding structures. What needs to be done at the policy level to better support these innovations?
Yeah, so one is we have to share those innovations and the successes of those innovations. But I think we have to, at the same time, understand that, yeah, my world is homelessness. I live there. But on the other hand, it may be the frail elderly. But I think the principles of listening to them, developing systems based on their needs, working with partners, those are common principles. So I think we can scale through those common strategies. But your community may be very different, and I wouldn't want you to take what we do here, but I would want you to see some of the strategies that can be generalized. And I think we have to support those strategies through funding organizations, et cetera, but we have to evaluate them. And we need to get health services researchers like the audience here engaged in doing that. And then that would help promote good, healthy social policy.
Okay, and sort of a good segue into the next question is sort of asking about a number of the researchers that would be in the CAHSPR audience, and asking, how do many of us who work in the disease-focused research help improve the outcomes of disadvantaged groups?
I mean, I lived my whole life in a disease model, but we have to start to get out of that. And I think some of the funding organizations here have to understand that as well, because they are represented in the audience as well. And I know that they have been starting to try and get their head around some of these different models. But if you take this population and you tell my clients, you ask them what's important to them, would you do this, for example, should you eat green leafy vegetables or something like that? And because that's going to make you healthier in 10 years down the road. They say to me, look, I'm going to be dead in another 2 to 3 weeks. I want an outcome that is meaningful to me, that you can measure, that actually changes my behavior and will change the support systems that provided to me that allow me to achieve that goal. And, it's very, very different, and it's very, very challenging. And social services research has tried to get their head around this for a while as well. And we need to have those partnerships. And, maybe the partnership is going to be with policing. It's going to be housing, social services, youth development. But we need to make those intersectoral partnerships and evaluate based on what the community thinks is important.
Okay, so the next question says, how can administrative data and health system research be leveraged to address these types of issues?
Yeah, so I mean, it can be, and it would be very, very effective. Remember a little bit about the data collection strategy about it. Some of my, there are concerns about collecting data from our indigenous communities, which is totally appropriate. Within my homeless environment, it's very, very hard to collect any meaningful, big data base information. They use aliases. They don't present to usual places like hospitals when they have a problem. And so you're left with much more community-focused data. Our 15 overdoses every day is not part of a big data system. It's a huge community problem dealt with in the community by and large. We don't phone ambulances, almost never. But it's a huge problem that the community experiences, that data doesn't find itself into a big database somewhere.
So the next question is asking you to elaborate a little bit on one of your earlier responses when you talked about the needs for governance and funding structures to change. And so the question is, could you elaborate on changing the governance and funding structures. Are there any examples you know of where this was done?
Yeah, so there are examples. And so let's just think of what that governance structure might look like if it's programmatic. Programmatic within health, there's efforts in Ontario through the Ontario Health Teams Initiative, where you're connecting acute hospitals with community and the needs of those community individuals. So there is early evidence that, or support, and that's not unique to Ontario. Those have happened many different places and settings, but they should be programmatic, targeted towards a unique community's needs. In my setting, homelessness, but it might be something else. But those partnerships, there'll be, we need them to happen, but we need to have a new governance structure, which has happened with the Ontario Health Teams, and a new funding structure that's followed that. If you look at other settings, we have, it's not unusual to think about funding and governance structures in cancer, in mental health. So there have been forays into this. What about a governance structure that involves improving Indigenous health? Should we not sort of engage that community in their own governance model with their own funding strategy and allow them to reach out to us to say, how would you organize dialysis for our community? And if they wish to have it not, then they'll find another strategy that suits them. So you can think about how this might evolve, but as you expand and think about it more, you have to start to think about, now I have to start to work with the housing sector. Now I have to work with social services and policing and the likes. And it becomes very complicated. Government, municipalities, etc. But nevertheless, it's the strategy that will work.
So the next question is sort of reflecting on the fact that your talk today is to the CAHSPR audience, and that the question says, we are all the converted. How do you pitch the good to those who are totally resistant?
Yeah, so I often think about who is it that's resistant. So if it's a community group, or if it's a charity group or something, I think you frame it in the things that are meaningful to them. And that would be that first kind of category of social accountability, if you will. If it is a group of decision makers within the government, I think you have to frame it in a different way. You could frame it in a human rights perspective, but frankly, in the end, I think you can make a very convincing argument that you should frame it in the perspective of a cost savings. Why should we put somebody with mental health issues in an addiction in a prison at $97,000 a year? Why would she put somebody in a shelter at $38,000 a year, or in one of my ICU beds at $2,500 a day? There's a convincing financial argument. The reason why we've been funded to deliver a health system for the homeless is we save not thousands, but millions to the healthcare system in Ottawa. I'll just give you one example, is that people who are homeless were repeatedly taken up to the emergency department. So we created what's called the TED program, where we bring people in and the ambulances bring people to us. And we divert about 3,500 ambulance visits to us away from the hospital every year. Huge cost savings and better care.
We've got about 5 minutes left, and I've got a couple more questions. So the next question is, would free education extended to university and college assist in reducing poverty levels?
If I was one of the smart people in the audience today, I would say, where are my biggest bangs for the buck? And I would say free education, yes, I suspect it would improve. Would it improve more than a return on investment in early childhood education or development? Would it improve more than a minimum wage? Improve more than dealing with some of the other structural impediments that people experience? I don't know the answer to that. I don't think anybody knows the answer to that. And I think there's a lot of smart people in the audience today who could turn their attention to saying, all right, we're going to do this. Here's strategically where you should invest first, second, and third.
Okay, the next question is sort of regarding the concept of learning health systems and sort of the interest that a lot of people in the CAHSPR community have. And the question is simply, do you see learning health systems as helping to solve these problems?
I do. You've got to listen. If you're going to be a learning healthcare system, you have to listen, and you have to be willing to adapt and adjust and have structures that permit that. I would like to think that most people, especially after hearing me today, would say, yeah, we've got a bit of a problem, but how do I change it? How do health systems allow evolution and change to take place to address it? And I like that concept. I just think that the nuances are you have to listen to what the needs of that community are, collect meaningful data, and promote change and affect those change in circumstances that are kind of resistant to change in the first place.
And I think the last question we'll go before we wrap up is just a question around to what extent do you think we are able to build the capacity going forward to address questions related to health equity and poverty in Canada? What are the things that would help us to improve that capacity?
Did you save the hardest toward the end, Mark? I think one of the things that would help us to build that capacity, I think that there are, there's many evidence, investment strategically, governance, engagement of communities, collaboration and partnerships, all would be important strategies. Is there one thing that's going to do it? No. But it's going to be those types of things all working together. And I think it's when the community mobilizes to say, this is a problem that we want to solve. Then I think you'll see change. I mean, look at what happened in COVID, for Pete's sakes. I was able to put half my homeless people to decant them out of a shelter where they were in those 70-bed rooms into hotels. We opened up isolation centers in a matter of days. So, we can do this. And I think that no problem is too big. I think that this is something that is imperative, but I think we can do this.
So thank you very much, Dr. Turnbull, for a great hall lecture. And you can see by the number of questions and challenging questions that there was a lot of engagement within the CAHSPR community. It's a very thought-provoking topic, and I think there's a lot more that we need to be doing in this, but I think there was a lot of information and insight from your talk and from your responses to the questions will be quite helpful. So thank you very much, our 2020 Hall Laureate and 2021 Hall Lecture. And I think we can wrap up this session.
Thank you very much to everyone.